Hi, this is Skyler Wood. I'm giving my presentation on systemic lupus erythematosus. And go. Okay, systemic lupus erythematosus, abbreviated SLE, is a chronic autoimmune disease. It primarily affects women ages 18 to 35. It affects 10 to 1 women to men, so women are way more affected than men. Um, And not only that, but estrogen-containing contraceptives and hormone replacement therapy increase that risk even more of getting lupus. And it's also more common in African Americans and Hispanics than in whites. Joint pain is the most common symptom that people present with, and also fatigue, tiredness, weight loss, malaise, general sickness, fever, symmetric arthritis of the small joints, that's like the hands, the wrists, the knees. Uh, there's a butterfly rash in 30 to 40% of patients. It's a very typical thing. Renal involvement in 50 to 67% of patients, and this is actually the most common cause of death from systemic lupus. And there's a whole list of other systemic effects: heart problems, chest pains from inflammation of lungs, seizures, cognitive problems, psychosis, depression, anemia, several blood problems. You can have anemia, leukopenia, thrombocytopenia, or lymphopenia. So all kinds of different problems with your blood. This is the typical butterfly rash that people see. And again, that's just in 30 to 40% of patients, not all. Okay. Lupus is associated with over 25 autoantibodies, most common ones being anti-DNA, anti-RNA, and anti-cardiolipin. And for you to have 25 different autoantibodies, that means there's something wrong with your immune system and its regulation. And in this case, it's regulatory T cells called Tregs. They're important for self-tolerance, um, and they do not perform as they're meant to in lupus. These Tregs suppress T cells. They keep T cells from entering into the body that are directed against the body. But in this situation, they actually die in early cell death, apoptosis, so they do not do what they're designed to do. Fc receptors for IgG on B cells are also abnormal, and they keep the B cells from being switched off. So that means that your B cells just continue to make antibody, and a bunch of that antibody is autoreactive, and not only that, but you're making too much of it. Th1 and Th2, T helper 2 mutations contribute to the upregulation of B cells through cytokine production, so it's just even further stimulating your B cells to make even more antibody because of the mutation. Alright. In this disease, there's many antigen-antibody complexes that are made. These complexes end up deposited in tissues, and that deposit not only causes tissue damage itself, but whenever it's removed by the immune system, it causes even more damage. The most common and dangerous site is in the kidneys. Well, definitely the most dangerous site. That's actually the most likely place for or way for someone to die from lupus is from glomerulonephritis. DPGN is diffuse proliferative glomerulonephritis. That's where you have cell proliferation in over 50% of your glomeruli. And yeah, that messes up renal function, and you'll end up having renal failure, and that can be deadly. Okay, there's autoantibodies against, okay, anti-nuclear antibodies, that's what this is about. This is for diagnosis. You have if you have lupus, you have autoantibodies against nuclear antigens, and you test for that with a fluorescent anti-nuclear antibody test. It's called FANA. Patients with lupus are 95% positive for the anti-DNA strain. False positives are possible. About 5%, I think, of the normal population has these anti-nuclear antibodies. So you really only want to run this test if they're already demonstrating signs of having systemic lupus. You don't want to just run it on everybody. Antibodies to the double-stranded DNA are the most diagnostic, and those will show up as a peripheral or homogeneous staining. I have a picture of that on the next slide, I believe. Those antibodies to double-stranded DNA are especially diagnostic when they're combined with low levels of C3 complement. And there's a picture of a homogeneous FANA test. It's 95% of lupus patients will have that. But even though this test is really sensitive, it is not very specific. You can also have ANA. You can also have ANA in biliary cirrhosis, mononucleosis, chronic hepatitis, other liver diseases, systemic sclerosis, Sjogren's syndrome, primary Raynaud's disease, and polymyositis. So you definitely want to only diagnose this in conjunction with other tests. Even though it is sensitive, it's not very specific. It can be positive for a lot of other diseases as well. Lupus actually you can have lupus because of medications, but if you get taken off the drug, the disease usually goes away. In these patients, instead of seeing the anti-double-stranded DNA, you're more likely to see anti-histone antibody. It may be combined with antibody to single-stranded DNA. So if you see both of those, that's especially diagnostic. Treatment can treat the symptoms. Fever, you just give high doses of aspirin or anti-inflammatory drugs. For skin manifestations, you can give hydroxychloroquine or chloroquine and topical steroids. Those first two drugs are actually malarial drugs, but they can also be used for lupus. Systemic corticosteroids to suppress the immune system. It just lowers the amount of antibody present in the body. And a new treatment involves removing the stem cells from the patient and harvesting them. And then you put the patient on chemotherapy, and then you replace them with the same stem cells. That's called a autologous stem cell transplant, because it goes from the same patient back into the same patient. And my conclusion is affects between 15 and 50 individuals out of 100,000 in the United States. And over the last 4 decades, the amount of cases has tripled. And diagnosis, again, is clinical symptoms and a positive ANA test. But don't forget that an ANA test also is positive for other autoimmune diseases as well. And the most common cause of death is renal failure. So that's all. Thank you for listening.